Welcome, everyone. Thank you for joining us for the third installment of the Improving Health Access series. We have a great session planned today, Behavior Change Communications for Community Health Innovations. My name is Judd Staples. I'll be moderating today's panel discussion. Before we start with the introductions of our participants, I'd like to start with maybe a few housekeeping things. For our observers, please turn off the video and mute your microphone during the initial part of the session. Please introduce yourself via the chat function. Let everybody know who you are. We will have time at the bottom of the hour for questions for our panelists, and also an opportunity for everyone here on the call to share their own experiences with behavior change communication campaigns, or successes and challenges, and to ask, to share their stories as well. So we're inviting everyone to participate fully in this discussion. So with that, I'd like to go ahead and start it off with the introduction of our panelists. Brian, do you want to start us off?
Sure. Good hello to everybody, wherever you are in the world. I'm calling in today from the East Coast of North Carolina in the U.S., and it's really a pleasure to be here today. I work at a nonprofit research institute called RTI International, where I am lead scientist for public understanding of science. I also have the opportunity to teach. I'm an adjunct over at Duke University in internal medicine, as well as appointments in a couple of other universities here as well. And I appreciate the chance to connect with everybody.
Great, thank you, Brian. Alice, please introduce yourself.
Hello, good afternoon. My name is Alice Onsarigo from Nairobi, Kenya. I work for Zana Africa, an organization that is based here in Kenya. And I am currently managing the programs in Zana Africa. I have worked with the organization since January this year and been managing the Pfizer gig project until now, with the hope of continuing in the future. I have had experience of working for other organizations over the past 23 years in the humanitarian sector and in the development sector. So thank you so much for having us here today.
Welcome, Alice. Thanks again for joining. Ndasowa, please introduce yourself.
Hello, everyone. And my name is Ndasowa Chitule. I am based in Malawi. I am a Deputy Country Director for VillageReach, Malawi. VillageReach is a global health organization. We support public health programs, mainly in the sub-Saharan region. We have country offices in Malawi, Mozambique, and DRC. And our focus is on improving access to health services for marginalized populations using innovative approaches. I currently manage the Pfizer gig project that VillageReach received, and I have worked in public health for over 18 years now, mainly looking at design, implementing, and also monitoring programs in the areas of HIV, sexual reproductive health, and health system strengthening. And in that space, I have engaged with BCC programming as well as other responsive programming. Thank you.
Thank you. Well, welcome. Thank you all for joining us this morning or this afternoon, as case may be. Great to have you all here. So I'd like to start the session off with Brian. If you could give us a little overview of behavior change communication.
Yeah, thanks so much, Judd. And it's been fun to see all the different titles come into the chat here as well. And I recognize that we're giving this talk to people that have regularly been thinking about behavior change communication. For many audiences, behavior change communication is a new idea. And what I want to offer here are some considerations lessons learned from the history of us doing this work, and different ideas that we ought to keep in mind, ideas that I think are often overlooked. So I'm going to share my screen here. And I'm just going to check with Judd for confirmation that that's working.
Yep, looks
great. Okay. So, all right, 1 second. So, as we embark on and think about this possibility for using new communication technologies to reach and persuade people, there are some really important ideas that we need to keep in mind. And I think one of the most important initially is to keep in mind that we've been doing this for quite some time, not necessarily always successfully, though. I used to work for the U.S. Centers for Disease Control and Prevention back more than 20 years ago. And during one of my lunch breaks, I went to their library and archives, and I was looking around through old reports. And here's one from now almost 100 years ago, from the 1940s. In which there's documentation of all kinds of efforts, to use the communication technologies of the day to reach populations, in the hopes of reducing malaria. And there were lots of different, strategies and approaches that they used, but really drawing on, thinking about, advertising at the time, thinking about, different ways that you might use communication to convince people to do what you want them to do. But unfortunately, for better or worse, this wasn't necessarily always successful. And part of the assumption that was made was that somehow simply putting the word out into the world would be enough for people to listen. As we know, that's sometimes not the case. Here's another example from even earlier, from the 1920s, of a simple pronouncement, to a population, to avoid illness, somehow. And of course, it's typically not that easy for people in practice. There are many more considerations that need to be kept in mind. And so that's something that I want to raise a couple of considerations here, which I think can help us, do better in that regard as we work with communities to keep them healthy. So, one place we can turn to for some of the observations are our recent experiences with emerging infectious diseases. Not only obviously with regards to COVID-19, but also we can think about the experiences that we've had with Zika virus and Ebola, and ways that we've worked with populations to attempt to keep them out of harm's way. And there are a couple of really important things that we've realized along the way. The first of which is that people are not blank slates. People come to any problem, any new situation with ideas in their mind already. And so the mental models that people have of disease, of health, really do make a difference. A great example of this is some work that we did in Guatemala with regards to the Zika virus. Guatemala is a place where mosquito-borne disease has been around for quite some time. And what we found was that many people were thinking about Zika virus as yet another mosquito-borne disease. And what was important about that was that while mosquitoes were a vector, it's also the case that Zika virus can spread through sexual contact. And people were overlooking that because they were thinking about Zika virus with their mental model of chikungunya or dengue, other mosquito-borne diseases. And so we've got to keep in mind what are in audiences' minds when we face new and novel threats. And we certainly saw that in many ways with regards to the early days of COVID-19, in which people were thinking about COVID using mental models of other infectious diseases, which may or may not have been accurate at the time. And that's something that is really crucial for us to keep in mind here. We also recognized during the course of the Zika experience that people have attention spans that move from one topic to another. There's a lot in the news. We all might be thinking really seriously about the particular health topic that we are concerned with. But we also know that that rises and falls in the minds of people, sometimes very quickly. Something we saw in the context of Zika was a very quick uptake here. There was an explosion of Google searches, of social media activity, corresponding to some of the news announcements, but that also quickly faded away. And that's something that's really, I think important, is that for many audiences, many communities we're working with, the topic that we most want them to be thinking about may not be top of mind for them. They might have other ideas that are more salient, and it's important for us to recognize the timing of the information environment as it exists, because we are not operating in a vacuum. Typically, we're often offering our ideas and amidst many others that are out there in the information environment. So any successful effort to use communication to change behavior really ought to follow a few steps, and each of these steps are places where we can make mistakes. First, we've got to actually decide what it is that we're trying to do, and to define campaign goals. We have to determine who it is that we are addressing our messages to, who our audience is. We have to really understand why it is that they're doing what they're doing, and not just assume that they're going to accept what we have to say wholesale. And then we really need to think about ways that we can creatively reach them with messages that are engaging, that address both who they are and why it is that they're doing what they're doing already, because people have good reasons for doing what they're doing. Even in the step of conceptualizing an audience, though, there are really important mistakes that we can make. How we talk about audiences matters in really important ways. This is something I've written about previously, that there are a lot of assumptions that get made sometimes when we talk about the prospective audiences for our communication efforts that I think guide what it is that we do end up doing, and sometimes we make really important mistakes. Here's an example from the U.S. context in our Environmental Protection Agency. Here's their description of different audience categories, folks that might be expected to engage in particular protective behaviors with regards to the watershed. And you can see here their classification of people is really problematic in some ways, especially as it comes to that last category, because there's a characterization of people that haven't done what it is that they want to do, they want them to do yet, as somehow being resistant to change. And I think that that's a mistake that we often make, that we characterize people as being inherently hostile or resistant, when in fact there might be all kinds of structural reasons why they haven't been able to do what it is we want them to do yet. So we've got to be careful even at the level of defining our audience. Beyond that, we have to recognize that campaigns operate in a very complex environment. The exposure to our messages is coming amidst all kinds of other social interaction. We have to think about existing policy norms and constraints that are on people's behavior. And even if we convince people to behave in a particular way, it's really important to recognize that there are all kinds of external constraints on what they are or aren't able to do. And so there are limits, I think, to what communication can cover. The conceptualization of audience also ought to keep in mind where it is that people turn to for information. We've got to think about typically where people are engaged with information, and we have to think about how it is we might actually successfully reach them in those places. And so one thing that's important to keep in mind is that there's no magic solution here for which channel to operate in. We ought not be assuming that we ought to always be using particular new technology, for example. Sometimes there are existing media channels or existing social pathways that are important to keep in mind. There's no single best choice across all circumstances for all audiences and behaviors. The last thing that I'll just leave you with here that I think often gets overlooked is the importance of, in thinking about those channels and in thinking about sources, the importance of trust. Trust is a crucial variable that I think often gets overlooked, and I think it's often misunderstood in some ways too. We found this, here in the U.S. context, in an example of a project where we were working to find out where people found out information about wildfire risks. And we recognized that people actually preferred local sources of information, partly on the basis of thinking that they had more in common with people in those local sources than they did with folks who were further away from higher levels of national government. And so that seemed to be a matter of trust. And so that raised the question, what is it that trust meant to people in this circumstance? And we asked them, and something that I think is important, as corresponds with the literature in really important ways. Trust is not just a matter of intellectual credibility. It's not just a matter of thinking somebody's smart. It's not just a matter of thinking that there are many letters behind somebody's name in terms of their academic degrees. We also know that trust really is often a matter of both the reliability and consistency with which messages are offered, but also a sense of shared interest between audiences and the institutions that are offering those messages. And if we haven't foregrounded what those shared interests are, we haven't necessarily given people reason to accept what it is that we're saying. So part of our communication effort may have to go into building and maintaining trust. I think that we spend way too much time simply blaming those who don't trust our institutions, and instead need to be thinking about how we can both maintain trust that does exist and build trust, and as a first step before endeavoring to change behavior through communication. So those are just a couple of initial considerations, ideas that I think are really important to keep in mind. I'm happy to hear what my colleagues have to say about this as well, and then to take your questions in a few minutes. Thank you very much.
Thank you, Brian, for that. It's a great overview of a lot of the issues that the innovators face in deploying behavior change communications out there in the field. I'd like to hear from two organizations that have some experience in that area. First, let's let Ndasowa, do you want to share your story? All right, yeah, you're muted. You can come up.
Yes, just sharing my screen. What's my screen? Sorry. Just a minute there. I'm trying to locate my screen.
Perhaps if would be helpful to have a couple minutes, and we'll have Alice go first.
Yes, maybe Alice go first. I had my screen open, but now it's not there.
Okay, great.
Alice, is that okay with you?
Yeah, that's fine. Can you see my screen?
Yes, Ken. I guess we're seeing not seeing full screen just yet, but we are seeing your slides.
Okay, so I'm just gonna go to the slide. Okay.
Perfect. Go.
Great. So I'm gonna share the project that we are currently implementing as a Gig 7 partner in Homa Bay County. And that's the COVID-19 and HPV vaccination campaigns that we are supporting the county with in Homa Bay County. Homa Bay County is in the western part of Kenya, right next to Lake Victoria. And we have been charged to support the county with ensuring 4,000 individuals have accessed HPV and COVID-19 vaccines. So far, to date, we have attained 5,800 of those. So our campaign had several components. I just want to ensure that my video is on. I don't know if my video is on. Is it on? Can you see now? But yeah. Okay, so put it on. So the campaign that we've been running in Homa Bay County had several components. And one of the Zana way of doing things is by co-creation, creating SBC campaigns together with the community that we serve. And therefore, in the beginning, in February, when we got the grant, we immediately kicked off the program by doing an assessment to assess the barriers that are preventing people from accessing the COVID-19 and HPV vaccines. And then we went ahead to map the health resources. And this is because we needed to know what are available in Homa Bay County, community, to which facilities are providing vaccinations. And so we did a mapping of the health services throughout the county. And then we developed materials to address these barriers. And this development was also a co-creation process where we developed the materials together with the communities, together with the kids in schools, and the community stakeholders, community gatekeepers, who assisted us greatly in figuring out what messages were right for the community, taking into consideration the social and cultural norms of the community, and also went ahead to develop hotline scripts and chatbot scripts that could help address these barriers that were that we identified during the assessment period. We also supported the county by training community health promoters who are part of the channels that we are currently using to amplify our campaign in the community. As Brian has mentioned, it's very important to ensure that your campaign is trusted. And some of the trusted health workers in the community are community health promoters who work very closely on the ground with the communities, and therefore we figured it's important for us to train them on the barriers and ways of addressing these barriers so that they are able to mobilize the communities around them to access these services. We also worked very closely with the government, especially to get approvals for conducting the project there, but also for the government to own the program. It's important that whatever government, whatever entity you're working with owns that program so that they're able to support it as you go along. So some of the challenges we faced and how we overcame them, one of the main challenge was the barriers and the assumptions. We found out during the assessments that there were very many myths, fears, misconceptions about HPV and about COVID-19. And so this was a challenge because obviously if people have this in their heads, then they're not going to go and get vaccinated. Some of the barriers that we found out were distances to facilities, transportation, lack of vaccines. Sometimes people went to the facilities and did not get vaccines, and then that became a barrier because then they didn't go back to get vaccinated when they had time. There were very many myths and misconceptions. Some of them, for instance, for HPV, many people in the community who knew about HPV thought or had heard that it causes infertility, and therefore they didn't want their children to get vaccinated. There was a lack of understanding and knowledge about HPV. People were not able to explain, or people did not understand that HPV is the virus that causes cervical cancer. So there was a lack of knowledge in that. They were not aware of the risk factors for HPV. They were not aware of how HPV is transmitted. So in general, there was a huge lack of knowledge and understanding of HPV. There were a lot of, as regards COVID-19, there was enough information, I think, just because the pandemic had just happened. And so many people in the community were aware of what COVID is, how it's transmitted, what the risk factors are. So that was not a problem. For COVID, the main problem was the myths, the fears, the misconceptions that were on social media, that they were hearing people talk about on TV, that were rumors around in the community, some of them being issues of infertility, issues of low libido, and issues of the vaccine not having been developed over a long period of time, and therefore they had doubts on the legitimacy of that vaccine. The government buy-in was not really a challenge, but we know that government buy-in can be a challenge in most cases. But luckily for us, for the government, they have all levels of for both things. Therefore, they welcome amplify the campaign in the county. In terms of other several competing press within the county, and therefore sometimes it was not easy to find government officials to work with because there were other activities happening in counties. Timeline is a big one for us because, of course, our project only goes for 1 year, and therefore it's a challenge because the co-creation process and the implementation process takes a long time, and therefore it's important for a project to have at least 2 to 3 years to be able to have time to create a package that is going to achieve that we are looking to achieve, and therefore 1 year programming is not enough for that. And those are some of the challenges that we faced. So channels that we chose, first of all, we have launch events. On the side there, you can see the picture of us with the county officials during the launch events that we recently had. So the launch event amplified our campaign because it was launched during 6 days of activism that happened last week in Homa Bay, and this enabled large numbers of people to be aware of the program. We also selected community and to provide information about both vaccines. And therefore we developed a hotline, which has a virtual call center and a chatbot, a WhatsApp chatbot where people can go in and engage with it.
That's so I think we've lost connection without. Alice is back.
Did you lose me?
Yeah, Alice, you dropped for a second there. You're going through your list of channels. So we don't see your screen anymore. But maybe if you drop your own personal video, that might give you a little bit more bandwidth for your audio and the screen.
Okay, let me turn off the video and see if I can reshare the internet connection is unstable. That's what I'm saying. Can you hear me? Hello?
Yep, we can.
Yes, we can hear you.
Yes, we hear you.
Okay. Okay, great. I'm trying to share the screen again. Just a minute. Can you see it?
Yep. Yes, we can see it. Yeah, you're right where you left off. So yeah.
Okay. Great. Okay. All right. So I was just talking about the channels, and I mentioned the launch event that happened recently. We selected the hotline and chatbot to be able to reach more people, because obviously using technology reaches more people than using individuals. But to amplify it more, we used community health promoters whom we trained on both vaccines, HPV and COVID, and we trained a total number of 48 community health promoters who are supporting us to amplify this campaign further. We also developed posters and leave behind materials. We also had radio interviews where we were joined by the county director of immunization in Homa Bay County, who further amplified the campaign. And I think, like Brian said, it's important to ensure that there's trust in your campaign. And I think for us, involving the CHPs, involving the county director for immunization in Homa Bay County, who came on radio and talked about our program and also talked about the support that ZanaAfrica has given them, amplified our campaign further. We have also utilized partnerships. This includes community-based organizations and other service providers, so that we are able to make referrals to service providers, and the CBOs who are present on ground are ensuring that they amplify this campaign through whatever gatherings that they hold when they are carrying out their programs. We have also used influencers and for social media, and these influencers were given to us by the communication department of the county. The county uses these same influencers to pass on various messages to the community. And so we had 5 of these influencers who posted our campaign on social media, on Facebook, on TikTok, on Instagram, and other pages that they post. We also have pad posters that are posted in kiosks where ZanaAfrica sells its pads, because ZanaAfrica has a social enterprise arm that sells pads in the community, and therefore each kiosk that is carrying the ZanaAfrica pads also has a poster that talks about our campaign. I'm just going to show you a few of the posters that we have. These are the posters that we have that are amplifying the hotline number that we are currently using as one of our channel. And so these posters, the 3 posters are just to enable the adolescents and young adults know that they can call this hotline and get information that they require, both on vaccinations, but also on other sexual reproductive health information that they may need to make health choices. So the posters have been posted all around Homa Bay County and also in other counties in Kilifi, Kiambu, and Nairobi, of enabling people to get information that they may not be able to get from other channels. We know that young people sometimes are fearful in asking questions about certain topics that are stigmatized or not, and would like a safe space to ask questions. And so the chatbot are that space for the young people where they can go talk to a hotline operator, ask information about sexual reproductive health, and also get information about vaccinations, both HPV and COVID-19, and which facilities around them they can go to access these services. We have also put in place vaccine amplification posters to amplify both vaccines. So the purple one here is to amplify the HPV vaccine, and the yellow one is to amplify the COVID-19 vaccine. And as you can see at the bottom, we also have information about the hotline and the chatbot where they can go and get more information about both vaccines, but also information about other topics that they might want information on. This is just a snapshot of how we have where we've placed our posters. Our poster is placed in kiosks, as you can see over here. On the doorway, there's a Zana Africa poster. This is in the middle is an example of one of our social media campaigns on Facebook, and then on the right side is a picture of our posters in one of the health facilities in Homa Bay, where they have been posted. So the results that we've had so far is we intended to carry out 4,000 vaccines in Homa Bay County, but so far we have been able to support the county with 5,800 people vaccinated, and we are still continuing on with the vaccination campaign, and we will continue on until the end of the project. In terms of engagements with the hotline, we have had around 472 engagements. We recently launched the hotline, but initially we had a soft launch with our community-based partners, and therefore calls were coming in. But so far we have had around 472 engagements on our hotline. We have had over 1,000 chatbot engagements, and we have disseminated through the chatbot over 800 messages on different topics, beginning with vaccinations, menstrual hygiene, teen pregnancies, COVID-19, UTIs, STIs. So there's a whole lot, GBV, gender-based violence, and several other topics. So in the last few months, we've been able to disseminate around 800,000 messages about various topics through the hotline and through the chatbot. Thank you very much.
Thank you, Alice. That is great. I think there's a few questions in the chat. Maybe you can answer those directly in the chat, or we can address them towards the end of the session. I want to give Ndasowa a chance to present her the story for VillageReach. So I guess can you stop sharing your screen, Alice, and we'll let so share hers.
You able to see my screen?
Not just yet, but
Not
there may be a
yet.
delay.
Okay.
Oh, I see something popping up.
Yep.
Okay, so so I am presenting for VillageReach, and I will focus on two interventions that we are implementing. So as I said earlier on, VillageReach, we don't do whole campaigns by ourselves, but we focus on innovations that improve access to care. But we have found that as we do that, we have to align ourselves with ongoing campaigns as we work with Ministry of Health. And so in terms of BCC, VillageReach, we believe that BCC is an interactive process with communities, which uses tailored messages and approaches to reach the people and to also develop positive behaviors. BCC can use various models, particularly focusing at individual, interpersonal, or community levels. And so this aligns with what we do, because as we try to strengthen access to health services, we are also using approaches that are applying behavioral theories around individual level, interpersonal, and community level engagement. I'm going to talk about Health Center by Phone, which is a hotline in Malawi that VillageReach has supported for a number of years, and also talk about our human-centered design approach, which is similar to what Alice was talking about in terms of co-creating solutions and how this aligns with BCC. The Health Center by Phone is an activity that VillageReach supported since 2009, starting small in one district and growing it, working together with ministry until it became a national hotline. And this is just to show the pathway that we went through. In some points there, we did evaluations just to try and see how impactful it is and how we are reaching people. So using this platform, the hotline provides different packages of information. So unlike having just using the hotline for one project, it is now positioned to address several health issues. It is a platform that we handed over to Ministry of Health in around 2020. And by handing over, it means that the Ministry of Health started to take on operations of the hotline, paying for staff, paying for routine costs and functionality. We still work with the ministry to provide technical assistance around developing, updating messaging that goes on the platform, looking at the technology, adapting technology as new technologies come on board. And that's how we continue to work with the ministry. However, in line with BCC, the hotline offers a package of health information ranging across various health topics: malaria, HIV, SRH, COVID-19, cholera. Ministry is also positioning it to be an emergency response call center, and we are supporting them to do that. So as ministry is doing campaigns around these different disease areas, the hotline adapts to support that component. People can dial in toll-free and also listen to pre-recorded messages that are an option. If you don't want to talk to a hotline worker, you can listen to a message. The hotline is also linked to a WhatsApp line that was just developed for COVID response. And the WhatsApp chatbot kind of provides also information around COVID. And so CCPF is an opportunity to provide that individualized or interpersonal response in a campaign setting. So some of the results, and before I get into the results, I think the main challenge that we are trying to address by supporting the hotline is increasing access to information. I think Alice, as well as the first presenter, had talked about how important it is for people to have information, and this is a real need, and continual access to information while a campaign is going on is also critical. So by using the hotline, I think we have seen a number of progressive results. I'll focus on the post-transition section, which is after 2020 onward, where we had seen now the hotline truly functioning as a national hotline. We have since the advent of COVID, we have seen the calls multiply fivefold. The hotline receiving over 110,000 interactions monthly, to the extent of that hotline workers would be overwhelmed and not be able to answer all the calls. Over 1.3 million messages on maternal health have been disseminated. Maternal health here is highlighted because this is the life of the hotline. But as we're starting 2020 going on, COVID response was added. And Malawi, experienced the polio outbreak, experienced the cholera outbreak. All these messages were added to the platform to align with ongoing broader campaigns that Ministry of Health was doing. And so we see that this is an important tool to complement broader communication, because when you go on the ground, you realize that people are looking for some specific questions to be answered. And when you direct them to say, the hotline is able to give you these answers, it creates that belief in credibility that they are going to get credible information, they are going to get reliable information. This is a reliable platform that is existing for a number of years, and then they can trust the information because this is information that has been vetted by Ministry of Health. A key lesson that we learned was that provision of health information alone with campaigns that are maybe messaged with captions doesn't work fully. You need to support those captioned messages with an accessible information line or information platform that targets your target population. For instance, the hotline can be sort of advertised for young people who are used to technology. It can also be advertised for older populations who can call in. So it kind of addresses the needs of certain groups of people in the community. What we have also done with the information on the hotline is that the hotline has a dashboard which collects data to track where are people calling from, what are they asking about, and we use that data to analyze that data to see what are the issues that people are asking about or concerned about. This is an example of the COVID response, just showing, using just the IVR where people were calling and listening in. You can see that people were, this is towards 2022 where COVID was waning down. But as people were thinking that COVID is not an issue, from the hotline, we could see that people are still asking questions. And the questions that were being asked were still, what kind of vaccines were being offered in Malawi? This is a trigger to say, to ministry, to say, we need to do more about messaging around what type of vaccines. There were questions about benefits of the vaccine side effects, what to do after vaccination, vaccine eligibility. So this data helps to, again, feed back into the ministry and also stakeholders in terms of designing the messaging that is going out there. So that's one platform that we're using technology to complement broader BCC campaigns. The other approach is the human-centered design approach. I think most public health managers are aware of this. This is basically a participatory approach that really starts at the core of what are the needs of the people. And the flow of the activity starts from community engagement, which is asking them what are their needs. Then co-creating with them in terms of how do we address these needs, and then prioritizing key solutions that you want to implement to address the core needs that the people have. This is an approach that we have used for our gig funded activity, where we ended up developing job aids, vaccine job aids, like posters as well as vaccine charts, because this was a need. Essentially, we were thinking, people are aware of vaccines. People know what vaccines are. But when we talk to the communities, it was like, yes, we know there's a polio campaign, but I don't understand how or when my child should go. So the gap was, I don't know the chart. There are so many vaccines that are coming to me. Why should I go vaccine again? I need to really know this is a true vaccine that the ministry is asking us to take. So we ended up designing these vaccine charts to help health workers disseminate information around the vaccine schedule in Malawi. This is what I've touched on. These are some of the challenges that we found in terms of resistance of communities to participate in vaccination, beliefs and misconceptions, as well as lack of understanding, which Alice touched upon, and opportunities that enabled us to do well in implementing this approach was that there was already ongoing campaigns around cholera, COVID, polio, of which we built upon to say, if you are getting this information from ministry, why are you not going for the vaccine? And from that point, we would engage to understand the deeper issues or barriers and work with communities, structures, as well as health workers to identify solutions. A good example is in the COVID era, where in one district, there were 2 communities that were literally refusing, completely chasing out health workers not to go near their communities, where we went in, conducted this co-creation process, trying to answer their questions, giving them the information that they needed, directing them to the hotline to access more information. And within a space of 3 months, we saw an increase of uptake of the COVID vaccine from 1% to up to 2%. This was after several months, the ministry trying to get COVID vaccine into that community. So we know that engagement at that individual level really helps and complements broader vaccine or behavior change communication drives. And in terms of looking at the strengths of the HCD process and co-creation process, it helps communities understand and stakeholders understand the real problems and tailoring the messages. It helps identify diverse solutions which are created through collaboration and also ownership of co-designed solutions, which makes sustainability also happen. And also engagement of all stakeholders in the solution, which enhances sustainability and collaboration. It might be time intensive, but I think the long-term sustainability is key so that you maintain the behavior change that we are looking at. A key lesson learned was that HCD approach is very effective in complementing ongoing MOH campaigns to target populations that are vaccine hesitant or that are not coming forward to take the behavior that they are being asked to take. Let me pause there and see if there are any comments or questions. Thank you.
Thank you so much for sharing the VillageReach story. That's very entertaining, and congratulations on such great success with your campaigns. I had a series of questions for our speakers, but we're getting towards the bottom of the hour, so I did want a chance for others in the audience to be able to ask questions. I see that some of the questions have already been answered by our panelists and their colleagues online in the chat. But I guess I'll just open up the lines, as they say right now, and please ask questions for Brian, Alistair, and Ndasowa, or as I said, feel free to share a story of your own or a message about your experiences with behavior change communication. Right, Brian, I see a question in here from Brenda. Do you see that in the chat?
I do, and I was just in the midst of typing a response to Brenda as well, but I'll offer that to everybody. Brenda raises the really important consideration that we not assume these efforts are in a vacuum, but that we've got to pay attention to local feelings about and responses to existing and past public health actions, some of which have been controversial at times. And I think that's a really important consideration. I think that transparency and acknowledgement of existing challenges can be an important first step, I think, to building and maintaining trust. And I'd suggest that those not be ignored. I think that's you've got to think about what the local landscape looks like, what the recent news cycle has looked like, and I think there are opportunities, frankly, to acknowledge ways in which guidance has changed, over time. I think there's ways to acknowledge even mistakes that were made, or the fact that ideas have changed as well. Something that's really important, that's really challenging when we're talking about communicating about science, is that the nature of science itself is iterative. We learn over time. and ideas sometimes change and get updated. I think that's important to really emphasize here, and that's okay. That's the way that science operates. But there have been instances in which sometimes government officials or others are changing recommendations on the basis of the latest new evidence. And I think getting people to acknowledge or to recognize that process can be an important first step too. But Brenda, I really appreciate you raising that. I think it's a great question.
Brian, any other questions from our audience? In the chat. Well, great. I think we're getting close to the top of the hour, so I want to thank our guests, thank our participants for joining us today and sharing their stories and lessons around behavior change communication. I think it was a very informative session with some real lessons in implementation out in the field, as it were, with some impressive results shared as well. Just quickly review at least what I heard is that behavior change communication is complex, and that there's no one simple answer. Messaging is happening in a complex environment with other competing messages and policy and operational constraints that the design. So therefore, the design of behavior change communication needs to be an interactive process. Co-creation with the community needs to be involved, as well as other actors and stakeholders like the Ministry of Health, and that trust, building and maintaining trust is essential in putting together these campaigns. Misinformation is often entrenched. Again, emphasizing the importance of building and maintaining trust, but also, as we pointed out, using feedback loops and new technologies and information to continually refine your messaging for specific misinformation, and to target particular audience segments can be important and impactful.